Enterobacter, Citrobacter, Salmonella, the causative agents of typhoid fever, Shigella, the causative agents of dysentery, and Yersinia group, a very important group of microorganisms. And most often we deal these sort of organisms in our microbiology lab as well as in our clinical practice. So let us start this particular group and we'll discuss Escherichia coli in the light of urinary tract infection, a very common community acquired and hospital acquired infection. And to start with, as this particular organism, Escherichia coli, is included in the group of Enterobacteriaceae, we must learn the group characteristics of Enterobacteriaceae. Enterobacteriaceae, they are a heterogeneous group of intestinal tract or gastrointestinal tract, having certain features like they are non-sporing, they are aerobic or facultative anaerobic. If motile, they are motile with peritrichous flagella. They ferment glucose. They usually grow in simple media and with production of acid or acid and gas. They reduce nitrate to nitrite and beyond nitrite. They are catalase positive. They are oxidase negative. So these are the features, the group characteristics of Enterobacteriaceae. All group members are like this. Exceptions are there. Say for example, Shigella, dysentery, which is catalase negative. These are the exceptions are there, but routinely the group characteristics are almost true for each and every bacteria of this group. Now, if we consider Escherichia coli, the causative agents of enteropathogenic, enterotoxigenic, enterohemorrhagic, enteroaggregative diarrhea, different types of diarrhea, UTI, urinary tract infection, and neonatal sepsis. This particular organism, we often heard this particular name, Escherichia coli, that's B. coli diarrhea, E. coli UTI, and often get the result of from the microbiology laboratory with E. coli or Escherichia coli UTI, urinary tract infection. 80 to 85% cases are of E. coli. But other than Escherichia coli, there are Klebsiella pneumoniae and Pseudomonas aeruginosa, hospital acquired, Acinetobacter baumannii, hospital acquired. And these are all the causative agents. Certain viral factors are also there. Fungal UTI, candida, can precipitate urinary tract infection. And so we'll discuss first the Escherichia coli, the morphological features and the antigenic properties of Escherichia coli. Then very quickly we'll start discussing the urinary tract infection precipitated by Escherichia coli and their characteristics, how to identify this particular group, how to prevent, and how to deal with the recent challenge of drug resistance in Escherichia coli infection, that is called MDRO. And I will also show you a automated system report of the Vitek report of Escherichia coli infection. And one most interesting thing, today we'll discuss that how to treat a patient of drug resistancy, as well as how to read a report of urinary tract infection, which will be very much beneficial for you. The reading of a report is very important. Often clinicians faces difficulty in reading a report of a microbiology report of Escherichia coli or any organism, urinary tract infection. So let us start one by one the PowerPoints. So learning objectives, we will discuss the group characteristics of Enterobacteriaceae, the classifications, different type of classifications are there. Escherichia coli, its properties, pathogenesis related to UTI, the laboratory diagnostic methods, the antimicrobial resistance in UTI, and AST reporting and interpretations of report. The characters of Enterobacteriaceae. Just now I told you that the intestinal group of organisms, heterogeneous, different group of organisms and their different properties. But they are gram-negative rods, gram-negative bacilli. They are facultative anaerobe, usually non-capsulated, non-sporing, if motile, motile with peritracheous flagella. Grow on ordinary media. It ferment glucose with production of acid with or without gas. It reduces nitrates to nitrites and beyond nitrites. This particular point is very, very important for Enterobacteriaceae. If you miss the particular point that this particular group reduce nitrates to nitrites and beyond nitrites, then the definition will be not be proper. For the proper definition, you must have to mention this particular line, that it reduce nitrate to nitrites and beyond nitrites. Maybe NO, maybe NO2, whatever it may be in this group, reduce nitrate to nitrites and beyond nitrates. Please don't forget, underline this particular line. They may be oxidase negative and catalase positive. Please write this particular group characteristics, and the group characteristics is really important for you for examination purpose. Don't forget, it reduces nitrate to nitrite. Now, classification of Enterobacteriaceae. This classification, there are so many methods of classifying bacteria. Barghi's manual is one manual where the classifications, nomenclatures, etc., on the basis of the genus, on the basis of the species, tribes, these are mentioned, and on the basis of this bacteria, they are classified. This is a bit difficult. Another system is proposed by Ewing's. The Ewing classification, we often follow this Ewing's classification, but recently there is a molecular classification, and after that the Enterobacteriaceae is regrouped, and a newer type of classification is that molecular classification. But for all clinical purpose, for the clinicians, we have to modify the classification, and one classification which will be acceptable for routine work in our microbiology lab, for our technician, for our clinicians, one method that is on the basis of a particular media, McConkey media. On the basis of that, we can classify this particular Enterobacteriaceae group into two halves. One is the lactose fermenter group, and another one is lactose fermenter group. So by the help of a particular media known as McConkey media, we can easily separate the Enterobacteriaceae group into lactose fermenter group and non-lactose fermenter group. The lactose fermenter group, they are E. coli, like Escherichia coli. Now, from today, you try to utter this particular word, Escherichia coli. No E. coli, sir. The examination table often we ask, name one causative agents of UTI. Sir, E. coli. No, sir, no, ma'am. Please mention Escherichia coli. This is the full word, Escherichia coli. Citrobacter, Klebsiella, and Enterobacter. These are all lactose fermenter. That means pink colony producer. In McConkie media, lactose fermenter means pink colony producers. Non-lactose fermenter are Salmonella, Shigella, Proteus, Yersinia. Non-lactose fermenter, Salmonella, Shigella, Proteus, and Yersinia. Although the Shigella group, there is one particular species known as Shigella soni. This group is late lactose fermenter. Now, regarding the lactose fermentation, we know that two particular enzymes is responsible for lactose fermentation. One is, can you name them from your biochemistry class? One is permease, another one is galactosidase, isn't it? They are responsible. Permease pushing the lactose inside the cell, and galactosidase breaking down into simpler form, which is been utilized by the bacteria. So, permease, if permease is absent, concentration, glucose concentration or lactose concentration fail to enter inside the cell. So, bacteria must have these two enzymes, permease and galactosidase, to be lactose ferment. If permease is absent, then only osmosis is left for the bacteria. Cell to cell contact, and gradually it will enter inside the cell. So in that particular case, the slow entry due to lack of permease is the late lactose fermenter group. Is the late lactose fermenter group. No permease, slow entry, late lactose fermentation. No permease, no galactosidase, non-lactose fermenter. Is it clear, sir? Lactose fermentation is only possible with the help of permease and galactosidase. Both present, lactose fermenter. Permease absent, late lactose fermenter. No enzyme, non-fermenter, or non-lactose fermenter. Okay? So from this concept, we can classify the Enterobacteriaceae into two groups, lactose fermenter and non-lactose fermenter. So the McConkie agar, the mnemonic is plant. What are the ingredients? Peptones, L, lactose, A for agar, very good, and neutral red, and T is tautocolate. Very good, distilled water. So these are present. So now in McConkie agar, we have modified that McConkie agar with adding this bile salt, which is responsible for this media to be selective. Why this media is selective? Because addition of this bile salt, it inhibits the growth of gram-positive organism or restrict the growth of gram-positive organism and encourage the growth of gram-negative organism. We now, in the modified system, also add crystal violet to inhibit the gram-positive organism. These are the new modifications of McConkie agar. So with this, they inhibit the growth of gram-positive and is the cause of the selectivity. Now, on the other hand, it contains lactose and neutral red. Lactose is the cause of differentiation of this medium. Lactose fermenter and non-lactose fermenter, we can be able to differentiate the organisms for identification of the organism. So lactose is there. That's why the media is differential. That's why the media is differential due to the presence of lactose. And then this one is the pH indicator is acidic. Pink color is responsible for this. Lactose is there in the media. We are inoculating the organisms. The organism ferments, utilize lactose, produce acid. As soon as acid is produced, then the medial pH, it goes down, and neutral red at that particular pH converts the color to pink. So why the color is pink? The answer is this. You often answer in other way. No, this is the reason. With increased pH, the neutral red is activated. That's why the colony colors are pink. Is it clear? বুঝতে পেরেছো তো? বুঝতে পেরেছো তো? কি হলো? বুঝতে পারোনি? আবার বলি মিডিয়ার মধ্যে কি আছে? ল্যাকটোজ আছে। এবার ব্যাকটেরিয়াটাকে তুমি তো মিডিয়া প্লেটে লাগাবে, তুমি লাগানোর পর ব্যাকটেরিয়াটা ইউটিলাইজ করলো, 37 ডিগ্রি সেন্টিগ্রেডে তুমি রেখেছো ইনকিউবেটারে, সেটা ব্যাকটেরিয়া ল্যাকটোজটা খেয়ে ল্যাকটোজটা ভাঙবে। ওর তো এনজাইম আছে, ল্যাকটোজ ফার্মেন্টার গ্রুপ, তার পারমিয়েজ আছে, গ্যালাক্টোসাইডেজ আছে, ওকে ভাঙবে, সিম্পলার ফর্মে নেবে, ইউটিলাইজ করবে ল্যাকটোজ, এটিপি চাই। তাহলে ইউটিলাইজ করতে গিয়ে কি হলো? ভেঙে ফেললো, ভেঙে কি হলো? অ্যাসিড ফর্মেশন হলো। তাহলে মিডিয়ার মধ্যে পিএইচ থাকে 7, যেই অ্যাসিড ফার্মেন্টেশনের মধ্যে চলে গেল তখন মিডিয়ার পিএইচ কমে এসে দাঁড়ালো 5.5, তাই তো? পিএইচটা কমে গেল। পিএইচ কমে গেলে আমরা একটা ইন্ডিকেটর দিই। ইন্ডিকেটর কি করে? ইন্ডিকেটর একটা পার্টিকুলার পিএইচ রেঞ্জে কাজ করে। যে পিএইচ রেঞ্জে ও এক্সপ্রেস করবে, ওর কালারটা কলোনির মধ্যে ইম্পার্ট করবে। তাহলে এখন যখন মিডিয়াটা এইটা কমে এলো পিএইচটা, তখন ওর মিডিয়ার থেকে ওই নিউট্রাল রেডের কালারটা নিয়ে কলোনি তৈরি হয়ে গেল ব্যাকটেরিয়ার। বোঝা গেল? এবার বুঝেছো? বেশ, তাহলে এটা যেন পরীক্ষায় উত্তর দিতে ভুল না হয়। শুধুমাত্র ওই এখন কি মিডিয়ায় তোমার ইন্ডিকেটর আছে বলে কালারটা হয় না। কালারটা কি কারণে হয় সেটা কিন্তু বলতে হবে এক্সামিনারকে। ক্লিয়ার? নাও নেক্সট স্লাইড। So the basic classification now on the basis of lactose fermenters, late lactose fermenters and non-lactose fermenters. Now the group is that lactose fermenters are Escherichia coli and Klebsiella pneumoniae. Late lactose fermenter is Shigella soni, no permease, and non-lactose fermenters Salmonella Shigella species, except Shigella soni because that Shigella soni is late lactose fermenter. So commonly tested with McConkey media. The modifications of identifications of Enterobacteriaceae, the differentiation between lactose fermenter and non-lactose fermenter is by growth on McConkey media. The method, the McConkey agar is inoculated with tested organism using the stick plate technique. Incubate the plate in incubator at 37 degrees centigrade for 24 hours at least. Then the result, the LF colony appears as pink colonies, you can see here. This is the pink colony here, and colorless colony, that is non-lactose fermenter organism appears colorless colonies in Shigella. Now the Ewing's classification, that is on the for the Enterobacteriaceae, the long group of 8 tribes, and the Escherichia coli is placed over here, and the first in the Escherichia, and the first group is Escherichia coli along with Shigella. This group is a bit complicated. Now to start the organisms morphology. Escherichia coli is a bacilli which is gram negative, and usually in specimen it is long slender organism, and the different species of Escherichia coli are there, known as Escherichia fergusoni like Hartmanni, and they are mostly found in human intestine but can be pathogenic outside and within GI tract. The detection of Escherichia coli, which is thermotolerant at 45 degrees centigrade in drinking water, indicates the recent contamination with human excreta. So identification of this particular Escherichia coli in drinking water, that is known as thermotolerant species, at 44 degrees centigrade. This particular organism is an indicator of water contamination. The antigenic structure from all gram-negative cell wall, we know that the somatic antigen, flagellar antigen, capsular antigen, and fimbrial antigen persist. The O antigen is nothing but lipopolysaccharide. Lipopolysaccharide is attached to the cytoplasm of the bacteria, and with the bacterial lysis, it can produce endotoxic shock. So that is the dangerous thing about the gram-negative bacilli, for all gram-negative bacilli. And the different serotypes are related to intestine. The earlier serotypes are in intestinal infection. Certain serotype 2, serotype 3, serotype 6, they are also related to uroepithelial cell infections. So this serotyping, almost about 170 serotype exists. So this serotyping is on the basis of somatic O antigen, and by which we can identify with the agglutination test the particular species, especially it is used in Enterobacteriaceae E. coli. This typing is done. The capsular K antigen, from the word capsule, this capsular K antigen, about 100 species are there, 100 types are there, and role of K antigen in neonatal meningitis is very important. So capsular antigen of Escherichia coli is important for neonatal sepsis. If you ask me that, sir, why this capsular antigen is important for neonatal sepsis, why it precipitates neonatal sepsis, I have only one answer. That the capsule, you know, that it prevents phagocytosis, inhibits complement, and the neonates specifically, the IgM antibody is absent. So this particular capsule, they can easily enter our system and the sterile spaces, and they can produce infection as there is no IgM. The fimbrial or flagellar antigen is of 75 type, and flagella is the organ of locomotion. So certainly it is a pathogenic factor, and 75 types are there for flagellar antigen. The fimbrial antigen is very important for urinary tract infection. Different types of fimbriae is important. If fimbriae is a short note, you can easily write this. The different type of fimbriae has definite role for uroepithelial cells or urinary tract infection. CFA or colonizing factor for enterotoxigenic strain, that is diarrheogenic E. coli, but mannose resistant fimbriae, the different types of their PMS, FIC, etc. And they practically hemagglutinated with RBCs that is not inhibited by mannose. Mannose is there in the urinary tract, and they are not inhibited. So mannose resistant fimbriae takes part in colonization. In the urinary bladder, it helps colonization, these mannose resistant fimbriae. P. fimbriae is another type of fimbriae. So just remember the mannose resistant fimbriae and P. fimbriae. P. fimbriae that bind specifically to the P blood group antigens present on human RBCs and uroepithelial cells. So for you, only to remember, for urinary tract infection, that colonization is facilitated or helped by the two particular type of fimbriae. One is mannose resistant fimbriae and other one is P. fimbriae. For pathogenesis, these are the two important factors: fimbriae, and fimbriae. The toxin produces three types of toxins are there: heat labile, heat stable, and verocytotoxin, like Shigella toxin. A verocytotoxin, this is responsible for enterohemorrhagic Escherichia coli or diarrheogenic Escherichia coli. When you read in the next class, the diarrheogenic Escherichia coli. You will read the different types of the diarrheogenic E. coli are there, and specifically there is that verocytotoxin is very important, as it can produce hemolytic uremic syndrome. That's why the verocytotoxin is very important. Hemolysins are also there, and it helps pyelonephritis. The cultural characteristics, as I have from the group characteristics I have mentioned, that the aerobic and facultative anaerobic, it grows between 10 to 40 degree except the thermotolerant strain. Grow in simple media like McConkey media, nutrient agar, may contain capsule, capsule, antigen is there. On McConkey media produce bright pink lactose fermenter. Now you know the bright pink lactose fermenter colony. Many pathogenic strains are there, hemolytic on blood agar. So let us discuss now in the light of urinary tract the importance of this Escherichia coli in urinary tract infection. The clinical significance of discussing this is that Escherichia coli uropathogenic strain, when this particular strain is producing UTI, this is known as uropathogenic, and when producing diarrhea, diarrheogenic E. coli. So you can classify the pathogenic effects of Escherichia coli with diarrheogenic, with ureterogenic or UTI producing, and other one is the neonatal sepsis producing. So Escherichia coli uropathogenic strain is the leading cause of urinary tract infection, 70 to 75% cases, which can lead to acute cystitis. Cystitis means infection of bladder, and pyelonephritis, the kidney infection. When involvement of the kidney is pyelonephritis. The route of spread may be ascending, maybe descending. Ascending, that is from lower urinary tract, from urethra to bladder and then to kidney. This is ascending infection. And descending through bloodstream, hematogenous infection. Clear? So route, hematogenous route, descending and ascending. Clinical presentation. Lower UTI symptoms and upper UTI symptoms. The lower UTI symptoms, the infection of bladder, infection of the prostate, prostatitis. These are under this particular group, the lower UTI, and upper UTI is kidney involvement, ureter involvement. Pelvis of the ureter when infected is that upper type of infection, upper UTI. The lower UTI symptoms is dysuria, means painful urination. Painful urination is dysuria. The frequency, repeated urination, and urgency cannot hold. Immediately you have to visit the toilet. So these are the features of the lower UTI infection. The upper UTI symptoms is hematogenous, so there must be fever, the flank pain, pyelonephritis, kidneys are involved, and nausea, vomiting, etc. There is one particular terminology, very recently, this is very important, is asymptomatic bacteriuria. There is bacteriuria, bacteria in urine, but there is no signs and symptoms, and nothing is there. Mostly this is related to catheterization. Urinary catheter is there, so there is no sign and symptom of urinary tract infection. Dysuria, frequency increase, urgency, and as well as increased frequency and pain. So these are all absent in case of catheterization. Certain points are important for UTI. One is the incidence rate, male versus female. Definitely female, they are the common value, commonly they are used to suffer this particular infection due to the narrower passage, short urethra, and the vicinity of the anal canal and the urinary tract. So the possibility is there. And also the menstruations, heavy menstruations is also responsible for urinary tract infection, common in case of the female. The asymptomatic bacteriuria in coli, this particular terminology is used nowadays, coli, catheter associated urinary tract infection, coli. So this coli, where asymptomatic bacteriuria, bacteria is there in urine, but no signs and symptoms. We'll discuss it. Uncomplicated UTI, no complications. That is, organism is very common, like Escherichia coli or Staphylococcus. The common organism, the common bacteria in a healthy female, otherwise that female is healthy, in lower UTI. So these particular three things important to classify. The uncomplicated UTI, often it is written in the prescription pad that uncomplicated UTI, that means the organism is common, the lower UTI involvement, and healthy female. Versus complicated UTI does not fit the above uncomplicated one. Complications are there. Pregnancy, diabetes patient, transplant patient. In these cases, immunocompromised patient. Complicated UTI. Another terminology, there are so many terminologies now used. The clinical variations, the lower UTI cystitis, the lower UTI, that means cystitis, infection of bladder, urethritis, infection of urethra, and prostatitis, also the involvement of prostate. An upper UTI is pyelonephritis and ureteritis. This is involving the upper UTI. So the factors are host defense, the uroepithelial flushing, drop by drop urine, they are flushing out. Ureter insertion, anatomical abnormality. The antibacterials in urine, TAM hotspot protein, the bacterial adhesions and interleukin 8, they are usually associated with host defense. The facts on UTI is women suffer more than male, that is due to short urethra, pregnancy, sexual intercourse, and honeymoon cystitis. The commonest organism for honeymoon cystitis is, can you name? Can you remember Staphylococcus? Coagulase negative Staphylococcus? Staphylococcus saprophyticus. Saprophyticus is related to honeymoon cystitis. The other factors, urethral obstruction due to following reasons: urinary stone formations. Protease is responsible for this urinary stone formation, and along with UTI. The congenital malformations, the neurological disorder, and catheterization, paralysis patient. Catheterization and cystoscopy. Cystoscopy and catheterization are responsible due to trauma. During insertion, it produces trauma. Usually cystitis is produced from fecal strains entering urethra. The other facts is community acquired versus nosocomial. Community te hoche, community acquired. Hematogenous hote pare, ascending hote pare, descending hote pare. Nosocomial UTI, hospitalization, mostly catheterization. The pyelonephritis associated organisms are Escherichia coli and Proteus mirabilis. Proteus mirabilis due to production of this urease enzyme. The Enterococci UTI and its risk. The Enterococci commensal of intestine and during defecation somehow contaminated with urinary tract. Enterococci. Enterococci is highly drug resistant. They are intrinsically resistant to penicillin, cephalosporin, and variable resistance are noticed with aminoglycosides. So very difficult to treat them, and even vancomycin resistance, teicoplanin resistance are now emerging. The emerging bacterial infection, MDRO, means multiple drug resistant organism, is a new threat. Escherichia coli, Klebsiella, Pseudomonas, Acinetobacter, they are highly drug resistant now. The commensals of urinary tract, the anterior urethra, full of commensals are there. So during the collection of the urinary sample specimen, we must be careful. We must give proper advice to our patient how to collect the sample properly. The procedure of collection, clean catch MSU, that means clean catch midstream urine. For urine culture, it is the midstream which is important, the mid portion of urine which is important. The first portion that contains the commensals of urethra, that is not required for culture purpose. So from the midstream you have to collect, and you have to advise properly to collect the material. You have to advise that the patient must clean with soap and water. The anterior urethra must be cleaned properly, and then without touching the container, you have to collect the urine. Wide mouth, plastic, leak proof, sterile container is required. So wide mouth, plastic, sterile, leak proof container is required. The first morning specimen may not be there. Fresh specimen is required. Specimen even in the laboratory is also acceptable, but the procedures must be followed carefully. Procedure of collections is suprapubic aspiration for debilitated patients, children, fail to voiding the urine, suprapubic aspirations. Collection for acid-fast bacilli in urine, the whole sample is required. The first morning specimen is required here for collecting or for the detection of acid-fast bacilli in urine, because tuberculosis is a possibility. So to detect acid-fast bacilli, for the only reason the whole specimen, the first morning specimen is required. Otherwise, for midstream urine, for other organism to identify midstream specimen of urine has to be collected. The catheter sample, how to collect the catheter sample? For catheterized patient, you have to clamp the catheter first, not from the bag. Aseptically, you have to collect the material from the tube with a syringe. I'll show you the procedure. These are now important for you to remember. So how to collect material from catheter, and collection for babies, posture change, tapping of the abdomen is required for babies to collect. Transport of sample. The patient is from the distal part where laboratory facilities are not there. How to advise them to collect the urine material? That midstream urine is required, and immediately within 30 minutes you have to deposit the sample. If not possible, the laboratory can preserve the sample up to 4 hours at 2 to 8 degrees centigrade in refrigerator. If there is delay in testing, you can preserve the sample at 2 to 8 degrees centigrade, maximum up to 4 to 6 hours. If the delay is more from a distant part, then 1.8% boric acid container is required. Then 1.8% boric acid container is required. Now you can test the sample even after 24 hours, maximum. So is it clear? From sample collection for the transport, we'll ask this question for transport, and you have to write this question to get the extra mark from the UTI-like questions. The laboratory diagnosis, specimen collection, the midstream clean catch urine, midstream clean catch urine. Justifications, I have already given the justifications of catching the midstream clean catch urine and catheterized patient. How to collect will show. Urine analysis, the routine analysis of urine to identify the pus cell, pyuria. How much pus cell is significant from the microscopical examination? Almost about 8 to 10 pus cell per high power field is suggestive of urinary tract infection. Then certain biochemical tests like nitrates and leukocyte esterase are also important, but these are not surest tests. Urine culture, the significant bacteria, 10 to the power, more than 10 to the power 5 CFU per ml, the colony forming unit per milliliter. With the bacteriological loop, we inoculate the urine sample on the McConkey media, the surface of the McConkey media. The particular loop size is 2 to 4 mm. The loop size is asked in the examination 2 to 4 mm diameter. And what is the holding capacity? The holding capacity may be 0.01 to 0.001 or 0.04 to 0.004. If 0.004, then you have to lift 250 times of urine from the sample to make it 1 ml, because results are expressed in milliliter only. But it is not possible to collect 250 times. So with the loop of 0.004 ml, we can lift 1 drop of urine only and inoculate on the plate of the McConkey media. And from the next day, we have to count the colony, 1 bacteria and 1 colony. Then colony count, say for example, if the colony count is 1000, then you have to multiply 1000 into 250, the multiplying factors. And here comes the colony count. So that colony count is important to express the significant bacteriuria. One concept is there, significant bacteriuria, that is CAS concept. CAS concept is significant bacteriuria. Any bacteria or any other bacterial count less than 10 to the power 5 is not significant. But 10 to the power 4 to 10 to the power 5 is maybe go on either side, because there may be possibility of infection, may not be. If the patient is taking antibiotic, there is chance of lower colony count. But less than 10 to the power 3 is insignificant. So bacterial count, colony count in a report, a laboratory report, is very, very significant, because significant bacteriuria is a concept and we treat the patient with the significant bacteriuria and also check whether the colony count is coming down or not. So colony count in a pathological microbiological report is very important. I will show you one report. Antibiotic susceptibility test usually done in Muller-Hinton agar. Muller-Hinton agar. We can also test this in nutrient agar. So Muller-Hinton agar is the media of choice. Why? The answer is that it is low nutrients. Nutrition is less. That's why excessive growth can be reduced. So Muller-Hinton agar is the media of choice for antibiotic sensitivity test. So the catheter, you can see, this is the catheter and this is the injection port, the catheter tubing, and here is the collection bag. Never collect sample from collection bag. Contamination rate is very high here. So you have to clump it here. After one urination, clump it here and collect the sample from this catheter portion. Wipe off with alcohol and then collect with the syringe. 5 ml urine is collected above the particular port. You have to collect the urine from here. The culturing of Escherichia coli, the midstream sample semi-quantitative culturing, that is the CAS concept I have just now mentioned, 1 lakh per ml of urine is significant bacteriuria. This is a short note for you, significant bacteriuria. Culture by universal standard loop method. The standardization of loop I have mentioned that loop size is 2 to 4 mm and the holding capacity of 0.004 or 0.04, 0.001 to 0.001, different types of holding capacity you can arrange and the multiplication factor will differ. The interpretations of fixed volume of culture on McConkey agar and interpretations of growth after 24 hours. The biochemical tests are there to identify the causative agents and serological identifications and antibiotic sensitivity test for community acquired or nosocomial patients. One by one to discuss is that the biochemical characters, glucose, lactose, mannitol, maltose fermentation with acid and gas, and typical strains of Escherichia coli never ferment sucrose. The mnemonic is IMBUC, IMBUC. I stands for indole test. Methyl red is M. V is a Voges-Proskauer test. Citrate is C. The urease is U. So IMBUC is the mnemonic. Indole and methyl red is positive for Escherichia coli and VP urease and citrate is positive for Klebsiella species. Because to differentiate these two, these are the lactose fermenter. So you have to differentiate between the lactose fermenters. Lactose fermenters are Escherichia coli and Klebsiella pneumoniae. One is mucoid colony, but other than that, there are certain biochemical tests to differentiate them. That is IMBUC test. There is also one mnemonic I cut. So that is IMBUC is another to remember this. The biochemical characters, this is written here, the Escherichia coli is IM positive and Klebsiella is BUC positive. Now the drug resistance have different types of ESBLers there, the AMP-C, carbapenemase, and the new antibiotic, we are waiting for new antibiotic, but last few years, last 10 years to 15 years, there is no new antibiotic is there. And the hospital infection control policy has to be formulated for each and every hospital to treat this MDRO strain, and hospital antibiotic policy is required. This is the antibiogram. You can see from the Kirby-Bayer-Dix diffusion method is the method what we do here, and this is the zone of inhibition. This is called the zone of inhibition. A particular drug is placed here. This is the particular drug and the zone of inhibitions. The bacterial growth is not, it is inhibited by the particular antibiotic here, because antibiotic diffuses out here and it prevents the growth of bacteria. And the zone of inhibition starting from one side to other side is measured. This is the zone of inhibition, and at a particular chart we have to identify whether it is sensitive or resistant. Now we can see here this particular group of antibiotics, this is resistant. The antimicrobial susceptibility, the empiric therapy versus targeted therapy. When the patient is getting his admission with the urinary tract infection and symptoms are there, we have to start one antibiotic. So that is the initial antibiotic which acts as per the regional pattern. Say for example here, the routinely we prescribe one antibiotic that is cephalosporin group, or we prescribe one antibiotic that is nitrofurantoin, etc., cotrimoxazole, and these are usually prescribed initially. And the targeted therapy is that after getting the particular report, which drug is sensitive here, and we have to change our antibiotic after getting the particular specific report. The resistant concern ESBL producing Escherichia coli is a threat. The carbapenem resistance means imipenem, meropenem resistance, and common antibiotics usually used with nitrofurantoin, fosfomycin, and trimethoprim sulfamethoxazole. And why these common antibiotics are commonly used? Because these usually never alter the gastric flora. We have to preserve our gastric flora first, because antibiotics can alter the gastric flora. So alteration of gastric flora and the vaginal flora is important for us now to prescribe any drug. So these three drugs are for primary treatment and also for recurrent UTI, these are also used. The catheter-associated UTI is coli. Pathogenesis is the biofilm formation of the catheter surface. Biofilm, a polysaccharide coating produced by the organisms, especially Staphylococcus epidermidis present on the skin, and with the groove they form, the biofilm they form, they often invite the other organisms like Pseudomonas, more resistant organism, and the exchange of the genetic elements, the drug resistance is transferred from one bacteria to other by conjugation, the most effective procedure. So the biofilm is produced and very difficult to treat if the biofilm is produced on a catheter. So it is really challenging for the clinician. And the preventive strategies are aseptic insertion, so there will be no trauma. And the early catheter removal, each and after, say for example, 2 weeks alter, or after, or 4 weeks after, we have to change the catheter. And common pathogens are multi-drug resistance organisms. The etiological agents other than Escherichia coli is 80%, and other organisms are Klebsiella pneumoniae and the Proteus mirabilis, Enterococcus faecalis. The rare pathogens are Candida species, and the nosocomial pathogens are Pseudomonas, Klebsiella. They are MDRO. In hospital strains, they are hospital acquired. Control by hydration and hygiene, and a hospital strategy is that by antimicrobial stewardship. There will be a common pattern and for each and every hospital, and minimized, you have to minimize the catheter use only when it is required, and as soon as you have to remove it, and vaccines are under development. Summary is that UTIs are primarily caused by gram-negative bacteria, mostly by Escherichia coli, and accurate diagnosis and susceptibility testings are essential, and preventive strategies are crucial in reducing the recurrence and nosocomial infections. The interpretations of report is very important. Now the last portion of our lecture is that the interpretations, the isolation of organism from the report, and the colony count is important to identify the significant bacteriuria. The selection of drug as per the CLSI guideline. CLSI guideline is there, where for each and every bacteria there is a guideline. So these are the antibiotic, that these antibiotics must be used by the clinical microbiology lab, and for each and every bacteria there is a guideline. And intrinsically resistant from genetically resistant. Say for example Proteus. Proteus is intrinsically resistant to certain aminoglycosides. So if you prescribe aminoglycoside, these are useless. In Enterococci, it is resistant intrinsically to penicillin, cephalosporin. So it is prescribing cephalosporin in enterococcal infection is useless. And testing antimicrobials with these sorts of antibiotics is also useless. So the microbiologist as well as the clinician must know which are the drugs that are intrinsically resistant for that the particular type of organism. Say for Proteus, say for Escherichia coli, Acinetobacter baumannii, Stenotrophomonas multifida. Different type of group of drugs are there, and there is a list from where we can identify that this group of drug is intrinsically resistant to this particular antibiotic. Never prescribe them. This is a medical legal problem also. So zone of inhibition identification, now you know from this earlier slide that zone of inhibition is calculated from one side to other side, including the disc from one side to other side. And MIC is a minimum inhibitory concentration, and therapeutic index, which drug to select. Now here is a report. This is a report of a urinary tract urine specimen aseptically collected, and this is the growth is Escherichia coli. The growth is Escherichia coli. Now, this is the antibiotic report, the report of Vitek. The identification analysis time, 88% probability is that this is the organism Escherichia coli, and the selected organism is that. The antibiotic sensitivity is given here. The antibiotic amoxicillin more than about 32, more than equal to 32 is resistant. So almost all drug are resistant. It's the MDRO strain. Here you can see the sensitivity is only with amikacin. Amikacin is sensitive, 4. Gentamicin is sensitive. Tigecycline is sensitive. Phosphomycin is sensitive. Colistin is intermediate. And trimethoprim sulfamethoxazole is resistant. So it is very difficult to prescribe drug for this particular patient. The choice is obviously oral antibiotic. Often we prescribe oral antibiotic for a patient, no? Patient try to avoid the injectio form. And now, no oral antibiotics is seen here, except phosphomycin. Oral sachet are there for phosphomycin. Phosphomycin is a very good drug to start with. Single dose, chance of resistance is less. Single dose of phosphomycin for this particular case is the drug of choice. So identification, calculating the patient's age is not there. Number 2, the PKPD, whether the patient is suffering from any immunocompromised disease, whether the patient is suffering from diarrhea, dysentery, where absorption will be less, everything, renal profile. Now calculating everything, we have to select one drug. You have to maintain the gastric flora, you have to maintain the vaginal flora. So here everything you have judged, and now your prescription is a phosphomycin. So to read the particular report is very important. You see first the MIC or the zone of inhibitions. Zone of inhibitions first, then select the antibiotic on the basis of patient's body weight, age, and the other factors.